Hello, and here we are to do cardiac video number 1. Cardiac seems to be a very hard topic that a lot of nursing students have when they're learning it. You got to go back to the basic A&P. We'll be doing some patho, and we'll be discussing what used to be critical care concepts like CVP, PEEP, wedge pressure, those kind of things, where now everyday nurses need to understand these concepts. So let's get started, and we're going to go back and we're going to review. This is kind of a rudimentary heart, of course, and we have to remember when the blood is down in our toes, all oxygen and glucose has been removed, so it comes up through our veins into the inferior vena cava to the superior vena cava, and then dumps into the right side of the heart. Now, when the blood is preloading or dumping into the right side of the heart, this is where we measure central venous pressure, CVP. Now, CVP is a very important concept. This is the amount of fluid or pressure coming back into the right side of the heart. Normal CVP, 5 to 10 millimeters of mercury, which your white count, normal WBC count, is 5 to 10. So CVP and white count are the same, 5 to 10. And as we do this whole series of videos, I try to bring out like things to remember, so that, because as a nurse there's so much, and as a student there's so much new information, that we try to keep the like things together. So CVP is the amount of preload fluid going into the right side of the heart. Now, we use this concept even on NCLEX questions and on testing questions for nursing students. Which order would you question the doctor giving you? If you had someone with a CVP of 3, they're dehydrated, they've been on the garage floor for 3 days, they have very little circulating volume, would you question with a CVP of 3 somebody ordering diuretics? Well, of course you would. You would really question that. What you want with a CVP of 3 is IV fluids to restore blood volume. The concept of CVP, let's say you have a real-life story of an elderly woman in AFib who's in fluid overload, and she has fluid CHF issues. She's going to go to the mall and go shopping, and she doesn't want to take her Lasix because she doesn't want to have to go to the bathroom all through the mall while she's shopping. So she doesn't take her diuretic. She stops and has a salty lunch with maybe a pitcher of salty margaritas, and she's in your ER that night. And what that is going to represent is her CVP is going to be about 14. She's holding on lots of fluid. She's preloading her heart. So you would anticipate the doctor to order diuretics like Lasix. You would question an order of IV fluids at 150 an hour. You wouldn't want that, right? Because she's already preloaded. The CVP is already high. So that's the concept of CVP. It's the amount of fluid preloading the heart, and that's how we apply that concept to certain cardiac questions. All right. So now we go in through our superior vena cava into our right atrium. This is our tricuspid valve. Put a T there. This is our right ventricle. Then the deoxygenated blood goes through the pulmonary artery. Even though this is deoxygenated blood and we're used to oxygenated blood being in arteries, it is taking the blood away from the heart to the lungs. Here's some alveoli. And around each alveoli we have capillary beds up tight and close so that oxygen can diffuse into a red blood cell and CO2 can diffuse out. Now here, this is right where you have that nursing diagnosis, alteration in gas exchange. Anything that stops CO2 from being excreted here or O2 from getting onto your red blood cell, this is where you have alteration in gas exchange, like in chronic obstructive pulmonary disease, COPD. Now that we have had our gases exchange, we go through our pulmonary vein. And the pulmonary vein now, I have got on this side, this is high oxygen and low CO2 levels, as long as I have good healthy lungs. Over here, on the right side, I had low oxygen and high CO2 levels. Now here we come from the lungs, the blood is preloading, going now into the left atria. The left atria, then the blood will go through the mitral valve into the left ventricle. Then this is going to blow out the aorta. blow it out, but I mean it's going to travel out of the aorta. All right, so here's our aorta. Now, when we review the pathway of blood, we want to be thinking about if we have any kind of valvular disease. Remember, when we're talking about the valves, the only heart sounds you should ever hear are valves closing. All right? You should only hear a valve close like you hear a door close. If a door opens creaky, like it needs WD-40 on it, that's when you have stenosis of a valve. Stenosis usually means like a narrowing. Well, in this case, it means a stiff stenotic opening of the valve. It could be like a creaky door. So if you have mitral stenosis, when that valve is supposed to be open, it's going to open creakily. So stenosis is a noise made when the valve is supposed to be open. So stenosis has an O for open. All right? Now, here we are. We're looking at the normal flow of blood. And let's do left-sided heart failure first, as we were talking about with our elderly woman in AFib who didn't take her diuretic. So now let's say CVP is 14. We're fluid overloaded. The blood's going to be coming in, going through into the left side of the heart, and now she's not only, she has AFib, the atria are quivering, they can't totally contract and squish the blood into the ventricles as they should. Because remember, we only usually speak of cellular depolarization in nursing school during cardiac. But we're going to be doing cellular depolarization in every video, because every movement has to do with cellular depolarization. My husband always picks on me and says my mouth depolarizes very rapidly. Now he would be correct, because I cannot move my mouth if I don't have potassium, calcium, chloride, everything in its appropriate amounts in order for cellular depolarization to take place. Now here, if I have fluid overload happening, the first thing that's going to happen when I'm trying to preload the left side of my heart with too much fluid is when the ventricles are trying to squish that blood out. They're trying to squish it out and they're having such a hard time. What's going to happen is it will back up. That right there is your first sign of left-sided heart failure, an S3. So in left-sided heart failure, your very first sign is a S3. The second sign, as this is backing up, it's going back into the lungs, plus you still have blood coming from the right side of the heart. Now this little alveoli has hydrostatic water pressure coming from both sides. So now when you exhale, the alveoli collapse. And then thank goodness for surfactant, and when you take a deep inhale, that alveoli can pop back open. And when he and a million of his friends pop open, that's crackles, where the alveoli are going against water pressure. So the second sign of left-sided heart failure is crackles from the alveoli collapsing on exhale. Then you're going to have increased shortness of breath, a dropping O2 sat, then it's going to affect your ABGs. Okay? With this left-sided heart failure, the lab value we're going to be concerned about here is BN, as in Nancy, P, not BMP, basic metabolic panel. This is BNP. BNP, think of it as nature's nitro. When the left ventricle is working hard to push this blood out, and it can't push it all out, and some of it's backing up, it sends out BNP. Your BNP should be below 100, although some research is now showing we can have higher levels of BNP and it not be left-sided heart failure. But for all intensive purposes right now, what we go with is research is showing that if it's the normal BNP should be under 100. So now, think of this as nature's nitroglycerin. When the left ventricle is trying to push this blood out and can't, it sends out BNP. That signals it is a potent vasodilator, nature's nitro. It's going to dilate the lumen. And that should ease the workload on the heart. Now, I've taken care of patients in an open heart unit with a BNP of 23,000, which means that left ventricle was under duress and a lot of hard work, working like crazy for a long time. That's kind of their SOS, help me, help me, help me, when they send out BNP. So that is one of the first lab values we're going to draw in the ER, is a BNP, when we suspect somebody's in congestive heart failure, okay? Another thing we can do is put a central line in the ER, hook one of the ports up to pressure tubing, and that will give us our CVP reading. So if we have a CVP of 14, we have a mitral regurg, where you listen and you hear lup-tum, 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 right over the mitral valve. Mitral valve is mid-clavicular line, fifth intercostal space. If you're listening there and you hear lup-tum, lup-tum, now you have an S3, a CVP of 14, and an elevated BNP. Your patient is in left-sided heart failure. If you're given questions or scenarios in school or on the NCLEX that have to do with left-sided heart, when they say heart failure, assume left-sided heart failure unless you're told right. Right-sided heart failure they have to tell you about, because that is very, let's say it doesn't happen as often as left-sided heart failure. Okay, so you're going to see a lot of left-sided heart failure in your nursing career. It's out there. It happens a lot. We live with it. We do with diuretics. We also will give you nitrates and beta blockers to dilate things. And now with left, it's an S3, crackles, shortness of breath, decreasing O2 sat, ABGs. What are the things we want to do about this? We want to go ahead. The first thing we got to do, we got to diurese. We want to diurese this person. We really hope for a big one. Let's give them some Lasix to make the Lupa Henley very leaky. Then we will put them on some inotropic drugs. If you remember back to pharmacology, which we have a pharmacology disc in the series, actually 3 of them, inotropes make the heart strong like iron, inotrope. And we want to put them on things like digoxin that'll slow the heart rate down and make a more forceful contraction to push the blood out. So we would do positive inotrope drugs plus diuretics. We also are going to do vasodilators, and that depends on the doc as to who's on, whether they're going to order nitrates. They also will go ahead and give morphine, because morphine decreases anxiety, but it also vasodilates. And morphine plus nitro is not 1 and 1 is 2. It's like 1 and 1 is 8. They together synergistically, they cause a lot of vasodilation. So this would, if we vasodilate this, we can get the blood out of the heart much easier. Now there is a drug out called Natracor. Natracor is man-made BNP. So this does dilate. But if we are hanging BNP on a patient, it does no good to do a daily BNP level, because you're pouring it into their blood, it's going to be high. So just be aware of that. All right? Now let's look at some right-sided heart failure here. Left-sided heart failure can lead to right. Do you see, if I had fluid backing up this whole time in the left, that if it went unchecked and untreated, it can cause increased pulmonary artery pressures, because I'm pushing fluid back to the right side of the heart and into the lungs. Anything that increases pressure in the lungs can create right-sided heart failure. So one of the things that can create right is left. Right does not lead to left, but left leads to right. Okay? So here now, this is backing up, increasing our pulmonary artery pressure because we're putting more fluid in. And then that would create a backflow of blood into the right side of the heart. Now, other things that can cause an increased pulmonary artery pressure and not be left-sided heart failure can be things like cystic fibrosis, anything that can cause pulmonary hypertension, high pressure in the lungs, chronic bronchitis, pneumonia, TB, cystic fibrosis. Any of those lung conditions can cause high pressures in your lungs. And then when the right side of the heart is trying to push the blood into the lungs, it hits resistance and it backs up. Now that is why we invented Viagra. Viagra was invented to decrease pulmonary hypertension. We just happened to notice a side effect. That's it. So now we use Viagra for its side effect and not its intended use. It was to decrease the pressure in the lungs. Well, that's why we can't use nitrates with Viagra, because they both will cause an unsafe drop in blood pressure. Because Viagra dilates and was invented to totally dilate our pulmonary vascular system so that we decrease our pressures in our lungs. So the right side of the heart is trying to push the blood into the lungs, but if I have left-sided heart failure, chronic bronchitis, cystic fibrosis, any kind of pulmonary edema issues, it's going to back up and cause the first sign of left-sided heart failure is tricuspid regurg and S4. Then it's going to continue back, and it's going to go up my carotids, and I will have JVD. I will get periorbital edema. I'm going to then back it up, and I will get third spacing of my fluids and edema in my tissues in my body. That's right-sided heart failure. Right-sided heart failure is an S4, tricuspid regurg. It's going to have periorbital edema, bounding carotids, bounding JVD, backing the fluid up into the body, so I'm third spacing my fluids. So with this, the main thing we have to do is decrease the preload on the heart, but mainly we've got to stop the high pressures in the lungs so that right-sided heart, the right-sided fluid can get in. Right-sided heart failure is more ominous than left, because right-sided, we're having trouble getting our blood in to get oxygen. In left-sided heart failure, we got our oxygen. We're having some trouble getting it all out to the body, but we can at least live with that condition. Right-sided is a little scarier and more acute. So you would see the patient with right-sided heart failure before you would see the left-sided failure, if you had to prioritize. Now here, as we look at this, we want to make sure we decrease our pulmonary edema and pressures, and then we might have to do some diuretics to decrease our fluid in the right side for right and left side heart failure. Now the next thing I want to go over with you, and remember I have a picture book that goes with this DVD so that you can have all the pictures. Let me go over the concept of MAP, mean arterial pressure, because the concept of MAP is very important. It used to be only a critical care concept, but it is not just a critical care concept anymore, because the people that are on these med-surg floors and telemetry floors are really sick individuals, and you have people on vasopressors, vasodilators right on the tele floors, and the everyday nurse needs to know more now about these concepts. So you all have seen a Dynamap, I know that, the electronic blood pressure machine. It gives you your systolic, your diastolic, and it gives you your MAP. Well, what does that MAP mean? MAP is mean arterial pressure. And we want our MAP to be right around 70 millimeters of mercury. That is our goal. All right, when we have that pressure, that's enough pressure to perfuse our brain, and it's enough pressure to perfuse our kidneys. Now, when you have, there are only three things in this whole planet that will ever give you blood pressure. That is the diameter of the lumen of your blood vessel. So if a blood vessel is open, wide, and dilated, blood pressure is low. If your blood vessel goes ahead and constricts, now my blood pressure is high in this lumen. And remember, around each of these arteries, or blood vessels, or capillaries, there's smooth muscle. Smooth muscle has to depolarize to constrict. So you still have to have your electrolytes in proper balance so that you can get cellular depolarization of the smooth muscle around your blood vessels in order to constrict and raise your blood pressure. So here, the size of the lumen of your blood vessel, that's one of the things that determines blood pressure. The amount of fluid or blood in your blood vessel, That's the second component that causes blood pressure. So if I'm fluid overloaded and I'm bulging my blood vessels with fluid, my pressure will be higher. If I'm dehydrated or hypovolemic, or if I have someone who's bleeding out on me, I'm losing all this volume, my pressure will be lower. So those are two of the three things that determine blood pressure. The third thing is the heart rate. The pump pushing all this fluid through is the next thing that determines blood pressure. And on cardiac, the second cardiac disc, I do all the antihypertensive meds. And all of those medications work on one of these three mechanisms of action. We give you nitrates, dilates. Give you beta blockers, slow down the heart rate, and dilate. So, and diuretics, removing fluid. So when we're going over antihypertensive meds, we're going to go back to this concept because all of the meds work by one of these actions. And the inverse is true too. If we have someone who's crashing, who's got a very low labile blood pressure, any of the vasopressors we do work by either speeding up the heart, vasoconstricting, and we hang saline to fill the vascular space. Those are the three things that can give us pressure. So these three concepts are the only way we can either elevate or lower our blood pressure forever and a day, and it never changes because the AMP isn't going to change on our blood vessels. So MAP is an important concept when it comes to, let's say, when we get to ICP, when we do in the neurodisc, you'll see how important MAP is. MAP needs to be like 90 millimeters of pressure to perfuse the brain when your brain is swelling. You need a very high MAP to push the blood up through the carotids and circle of Willis to perfuse that brain. MAP is also an important concept when it comes to urine output. All urine is filtrated blood. I'll never forget the first time I had taken my critical care course, I had taken my open heart course, I'm taking care of my first open heart patient, I'm calling the doc to give him my wedge and my PEEP and all my cardiac output and all these numbers. And all he wanted to know was how many mLs of urine an hour are they making? And I'm like, oh, but my cardiac output, he's like, die. How many mLs of urine are they making? And it was at that point I realized, because he told me, he goes, as long as they're making 0.5 to 1 ml per kilogram per hour, they're perfusing. They're fine. So if you have someone who hasn't put urine out in their Foley at all, you might want to be seeing what their blood pressure and their MAP is. Because all urine is filtrated blood. If you have a person who, let's say the MAP is in the 60s, all right, and the formula for this is diastolic plus systolic divided by 3. Let's say we have someone with a 90/50 blood pressure. 50 plus 50 plus 90 divided by 3. I believe that's like 63.33 millimeters of mercury. That's a pretty low MAP right there. And I don't want to cross over and get this below 60. Remember, if we have a MAP go below 60, we're killing nephrons in 20 minutes. Because when your MAP is in the 50s, you don't have enough blood pressure to perfuse the kidney, to get the blood and oxygen to the nephrons. I like to use the example when I'm doing lectures. Have you ever taken a shower? And you're sudsing up your hair, you're soaping it, and then somebody flushes a toilet in the house. And now you don't have enough water pressure to perfuse the shower head to get the soap out of your hair. Well, when your MAP is not at least 60, you'll want it to be 70, but if your MAP is down where you now have crossed below 60, you are in trouble. Because you're killing nephrons. So here, you need to really pay attention to that mean arterial pressure concept, okay? So with this, if I had a low MAP, I wouldn't be giving any antihypertensive meds. I'd be calling the doc, I'd be holding it and saying, hey, my MAP is low, here's my blood pressure, and you'd have to get an order to hold the med. And sometimes we may have to bolus with fluid to get our pressure back up to where it needs to be. Some docs will order fluid challenges to see if the kidneys will respond and make urine. Usually, if your MAP is below 60, you're not going to get a lot of urine. And remember, 60 is a very common number, isn't it? If the heart rate is 60 or less, you're going to hold your digoxin, your beta blocker, or calcium channel blocker, aren't you? Because you're going to be slowing down the heart rate. So 60 is common for that. So 60 is a common for your MAP. Below that, you're killing nephrons. If your heart rate is less than 60, that's when we hold medications. And also, when we get to ABGs, on the ABG video, when your PaO2 is 60 or less, if it's less than 60, that defines respiratory failure. So 60 is a magic number to remember in nursing, that it helps that we know when we hold our our blood pressure medications, when the heart rate is 60 or less, we know that we'll hold our antihypertensives if our MAP is getting close to 60, and if our PaO2 is 60 or less, that defines respiratory failure. Okay, so there's the rule of 60s, and that is your concept of MAP, and knowing that you have to keep an elevated MAP in order to have a good urine output. Now, the next thing I want to go over, now that we've explored the concept of MAP and its importance, and we have done right and left-sided heart failure, we want to look at cardiogenic shock. Okay, for this first I'm going to do hypovolemic and cardiogenic shock. When you have, this is the outside of the heart, the aorta comes out, loops around. I'm having drawing difficulties today. Here we're feeding our coronary sinuses. These are all our coronary arteries. Obtuse, marginal, LAD, right anterior descending, all those things. So now we go ahead, RCA rather, right coronary artery and LAD. Now here, the first one to eat as the oxygenated blood comes out is it feeds the heart tissue through the coronary sinuses. Then it goes ahead and it feeds the carotid arteries. We feed our brain next with fresh blood. Then we have the aortic arch come around. And of course we have some bifurcations, but let's go down here to our iliac crest and where we're feeding our legs. Okay? When you're in cardiogenic shock, the problem that's causing the shock is the pump isn't working right. Remember the three things that we said give us blood pressure: diameter of the lumen, the heart pumping through, and the amount of fluid. Well, here we have a problem with the heart. In cardiogenic shock, it could be a massive heart attack, that we've had a clot here and that it has stopped oxygenation of our heart muscle, and now we can't pump correctly. It could be viral cardiomegaly, where a virus attacks the heart tissue and just eats it up and makes it like a sponge, so it doesn't have the actin and myosin that can contract and make a good cardiac output. So when we have cardiogenic shock, we have to support the pump, the heart that is pumping. And that's one of the things that can be very difficult. I mean, when we do hypovolemic shock, you stop the bleeding and you restore the IV fluids and bada bing, we're good. Here, cardiogenic is one of the hardest shocks to deal with because the major pump pushing all this blood is not pumping right. Now, some of the things we could do if we wanted to give our heart a rest, because the heart, the more it pumps and the harder it pumps, the more oxygen it needs, and the more, that's called increasing its myocardial oxygen demand. Well, we want to make the workload easier on the heart. So we would like to vasodilate certain things out to make the blood easier to get out. But on the other hand, we may have to use vasopressors out in the periphery to give us blood pressure. So we may want to dilate this part and vasoconstrict the outer part. And remember, not all shocks are the same. When I'm going over, when we're doing antibiotics on the farm disc, we are going to go ahead and we'll go over septic shock. That's a warm distributive shock. All the blood is out here in the periphery. All right? All the blood's out in the periphery. Where here with cardiogenic shock, when we can't perfuse our body, our body starts clamping down its fingers and toes and then shunts the blood to the core of our body. And then if we still don't fix this problem, it's going to shut down our kidneys, our gut. It's shunting the blood to the lungs, the heart, and the brain. So we want to make the workload on the heart as easy as we can. And one of the ways we can do that, we can use an LVAD, left ventricular assist device, where it's actually helping the left ventricle push the blood out to the body. Or we can use a balloon pump. Now in a balloon pump, you have the balloon pump here. It's hooked up to the EKG. You have leads on your patient. And you have, the doc has inserted a catheter into the aorta. Now you do not want this going up into the aortic arch. This is going to puff out a balloon. It's called a balloon pump, and it's going to decrease the workload on the heart and increase myocardial oxygen supply. Now how it does that is usually the left ventricle is squeezing hard to force the blood out. That's during systole, right? Systole is when the ventricles contract. Well, when the ventricles contract, that's called our QRS. The P wave, QRS, and T. The P wave is not only atrial depolarization, when the atria contract, that is also known as ventricular diastole. That is when the ventricles are dilating with blood because the atria are contracting during the P wave and the tricuspid and mitral valves are open. So now my ventricles are dilating with blood. So the P wave represents now not only atrial depolarization but ventricular diastole. So now the ventricles are filling with blood, and as they fill with blood and fill with blood, as they get full they slam shut the tricuspid and mitral valve. So the S1 is right there after the P wave, okay? S1 shows up right after the P wave. The QRS here is ventricular depolarization. That's when the ventricles are full of blood and they squeeze and they force open the aortic and pulmonic valves and they squish the blood right out to the body and to the lungs, okay? Then when the ventricles have squished all the blood out, aortic and pulmonic valve slam shut. That is your S2. Second heart sound is heard right after the ventricles have emptied their contents. And the T wave is ventricular repolarization. There is a atrial repolarization wave, you just can't see it behind the big QRS, okay? When the ventricles are depolarizing. The reason I went over this is because with this balloon pump, the balloon dilates during diastole. So we said ventricular diastoles during the P wave. So that means every time I have a P wave on this balloon pump, this balloon right here is going to go poof, and it's going to fill my aorta. And what it does is it backflows blood retrograde and will reperfuse the coronary arteries with oxygen-rich blood. Then the minute that the ventricles are ready to contract and squish the blood out to the body, we want this balloon to, it sucks itself in and gets real skinny. And when that balloon gets real skinny, it creates a vacuum. And the vacuum pulls the blood right out of the left ventricle through the aorta and then helps decrease myocardial oxygen demand. It makes the workload on the left ventricle easier. Because when that balloon was big and he was poof, he pushed the blood back, fed the heart again. Then he saw that the ventricles are getting ready to depolarize, that balloon deflates, gets skinny, and that vacuum that's created by this getting skinny just literally pulls the blood out of the left ventricle. So that decreases the workload. And that is one of the interventions we use for cardiogenic shock. We also will use vasodilators with peripheral vasopressors if we need to. But one of the big concepts is a balloon pump, and it's very confusing to understand how this balloon can help. And I hope that clarified that a bit. Of course, we will use drugs to try and help, positive inotropic drugs. Digoxin, jobutamine, and we'll be going over that more in the farm disc, the farm series. Now in hypovolemic shock, here we are with our blood vessel, and we should have a nice amount of blood in that blood vessel. But here, when we're bleeding out, or we're hemorrhaging, and now we have very little blood in there, that's going to drop our BP, drop our MAP, decrease our urine output. And if I don't have a decent MAP or blood pressure, I'm going to be dizzy and lightheaded because I can't perfuse my brain. I'm going to have decreased, if any, urine output because I'm not getting blood to the kidneys to perfuse them. So your number one thing is to get an IV site and hang saline because it's isotonic. And it's isotonic, it'll stay in the blood vessel. And that's what we want. We want to fill this up. So your number one intervention right away is to get an IV in and hang saline and then stop the source of the bleed. You're trying to find what is causing this. Now, if they're bleeding like crazy, of course you're going to put a tourniquet on it before you start the IV, okay? But if you see that they're really dropping low in their blood pressure, you don't see an obvious site for bleeding, you at least need to get the IV started, get the saline going. But if they're like gushing from an arterial bleed, you will put pressure on it, get a tourniquet, and start an IV because you're stopping the bleed. Okay, so those are two different scenarios that can lead to this. So that changes what you do first. You see the obvious bleed, you stop it, put a tourniquet on it. If you don't know where they're bleeding, or it's internal, you don't see it, you don't know where to apply pressure, you at least get that IV in, and you hang saline first. That's why in every code card we got saline right there, because we know we got to fill this vascular space. Now, and that is one thing that I wanted to go over too with you is fluids. I bet we'll do isotonic, hypo, and hyper in this video because we're talking about isotonic fluid filling our vascular space. And it's isotonic, it stays in the vascular space. But let's talk about when you would question an order for hyper or hypo fluids, or when do you want them. So we'll go over that. All right, so when it comes to hypovolemic shock, your compensatory mechanism, your body, has baroreceptors in the periphery and throughout your body. And they pick up on pressure. And when we are dropping and we don't have the blood volume, what happens is we're going to go ahead and we're going to have an increased heart rate because he's trying to make up, the heart's trying to make up for the lack of volume. We're going to get peripheral constriction. The smooth muscle around my blood vessels is going to constrict, and it's trying to shunt the blood to the core. And it's going to say, oh, well, we can live without fingers and toes, shunt all the blood to the core. Now, would it make sense if my arms and my legs, the blood flow is being cut off by the body trying to compensate, it's clamping down to push the blood to the core. Would it make sense to have an IV out here in the arm? Would it make sense to have a pulse ox on a finger in hypovolemic shock? Absolutely not. Because these are going to, the extremities are getting cut off from blood flow because our baroreceptors have signaled to your blood, to your brain, constrict, constrict. We need to shunt the blood to the core. We're dying here. So you want to be thinking, does this make sense to have a IV site here? You're going to have a hard time getting an IV site in because the blood vessels are so constricted. You're jumping up and down for someone to drop a central line. You want a central line so you can do large amounts of fluid to fill your vascular space, and you want your pulse ox on the ear or the forehead. You don't want a pulse ox out here. You do not want your IV out here, or it's going to be hard to get one in if you do. Okay? Now, let's move to the hypotonic fluids, because osmolarity does not seem to be discussed very much in schools, and yet a lot of concepts. We use osmolarity of fluids to fix so many things. When we get to ICP, the neurodisc, we use hypertonic fluids to suck the water out of the brain. We do use osmolarity a lot, osmotic diuretics, mannitol all the time. So here we are. Let's take a look. You go into your clean room and you pick up a bag of normal saline and you look at it. And have you ever read the fine print on it? Go ahead and just read the fine print on the IV fluids. You'll learn a lot. It gives you the pH, it gives you all the electrolytes and everything in the solution, and it also gives you the osmolarity. And think of osmolarity as concentration. It's the push-pull power of water. And remember, your body wants homeostasis. So it wants things to be balanced on either side of a membrane. All right? So when you read a bag of saline, it says its osmolarity is 308 to 310. Well, that means my cells have to be 308 in their concentration, or 310, because normal saline is 308. So if they had a tug of war, 308 and 308, who would win? They'd have a draw because it's equal on both sides. That's why normal saline stays in the vascular space, because it's the cellular osmolarity and concentration. Okay? Now if I have hypertonic fluids, hyper is a number higher than normal saline. So let's take like D5 normal saline. This has sugar and a lot of salt. So you can see here I'm trying to simulate like a very concentrated liquid here. Now I don't have it in my brain right here. I think it's like the osmolarity could be, it's greater than 308. It could be like 400, 450. Anyway, it's greater than 308. You'd have to read the bag. And what this says right here is that if this is, let's say, 400 or 450, a hypertonic fluid, and they had a tug of war, who would win? It would be the D5 normal saline. This is a hypertonic fluid. So it's going to, water is going to come out of the cell to dilute this. Now this would be a wonderful solution. Absolutely great thing to give someone. If this was pulmonary edema or a swollen brain cell, because this is my blood vessel, these are my cells by the blood vessel. And let's say that I have a brain cell here all swollen with fluid. I would hang mannitol. Mannitol has so much sugar in it, it's like osmolarity is close to 800. And that will just suck the water right out of the cells. So anytime that we have fluid overload in a cell, we want to hang a hypertonic fluid to suck that fluid right out. Okay? Then if this was a swollen brain cell, we can hit you with mannitol. It pulls the water out of your brain, and then we can hit you with Lasix, and you're literally urinating your brain water out. Now the next thing here we can look at is hypotonic fluids. This is any number on a bag when you go in the clean room and you're looking at your bags that's less than 308. Let's do like half normal saline, 0.45 normal saline. It only has half the salt of normal saline. And its osmolarity is around 150. If they had a tug of war, who's going to win? The hypotonic fluid is going to go into the cell. It's hypo, it's lower than 308, and it goes into a cell. This is a perfect fluid to hang for that person with a CVP of 3 who is probably intracellularly and intravascularly dehydrated. So a lot of times when they're really that dehydrated, the doc is going to order normal saline to fill the vascular space, and then he'll say alternate with a bag of half normal. Then when that bag's in, hang saline to fill the vascular space, then hang a bag of half normal, because that's going to go in and hydrate your cells. So you would question you would really be ding, ding, ding. And what if I had a bulging lung, my lung cells are full of fluid? Do I want to hang a hypotonic fluid that's going to go into the lung cell? Absolutely not. I don't want that, because that is wrong. Just wrong, going to cause more fluid to go in and cause further pulmonary edema. All right? So this is how osmolarity works between hypo, hyper, and iso. Now, when we get to our endocrine and diabetes disc, this is how diabetes kills cells. Because diabetes, it makes your blood hyperosmolar, hyperglycemic, lots of sugar in here. And it acts just like mannitol, like a hypertonic fluid, and it pulls the cellular water out of your cells. So what if that was a baby retina cell? That means that the water is getting sucked out as your blood sugar is high, and that's why we go blind. What if that's a baby nephron cell? Well, it's getting the water sucked out of it, and it can't live without its intracellular water. Remember all your cellular components. You have to have your Golgi apparatus and your nucleus and nucleolus, and all those things have to have intracellular water to operate. So this is how diabetes kills our cells, is through hyperosmolarity. And we'll be going over that when we get to the endocrine tractor. Let's see here. To revamp, when it comes to, I wanted to mind map real quick, left-sided heart failure for you again, so that you can you can get any of our mind maps off the website. Now here is the patho. It gives you a brief rendition of what can cause left-sided or congestive heart failure. So this is left-sided. The patho here, fluid overload. This also can be any kind of protein deficiency. If your protein's low. Remember back to the A&P. When you have protein in your blood, you have oncotic pressure. So here I have a blood vessel, and if I have albumin in here, which is a protein, that gives me oncotic pressure. Oncotic. That protein pulls and keeps water inside the blood vessel. So a lot of times if people have third spacing edema, they can have lower albumin and prealbumin levels. That can be part of it. People who are on high protein diets very rarely have puffy ankles because they have so much protein pulling the water and keeping it inside the vascular space. Now here we also could have had an MI. It could be hypertension. They could have a very bad AFib, atrial fibrillation, and we go over all the cardiac rhythms in our EKG disc. These are the things that can cause this. Another thing, the medications we use are on there. Let's see, we also have our labs and our tests and diagnostics. And the next one over here, we're going to do our patient signs and symptoms. And then you want to know nursing interventions. What are you going to do about all this? So the first thing that can happen, we said the first sign of left-sided congestive heart failure was having a S3, right? They're going to have that third heart sound, mitral regurg. Then the next thing they're going to have is crackles. Then they're going to become very short of breath, SOB. Then they're going to have a decreasing pulse ox, O2 sat. They also will have drop in their ABGs eventually. Now, and here you're going to have an increased heart rate, because as the blood is trying to circulate more oxygen, because we're not getting there, and the heart will increase its rate to try and perfuse the tissues. Now, what are the lab tests? We said that we would draw a BNP, and that shouldn't be greater than 100. But being that they're CVP, we could put in a CVP line, and the CVP will be greater than 10 millimeters of mercury. The BNP is probably going to be greater than 100 if they're in true foment left-sided heart failure. Another thing too over here, usually with our patient signs and symptoms, we will have a decreased urine output. Okay? Decreased urine output. Back to our test. We will do a chest x-ray, because usually on an x-ray you should just see white bones, right? And you should, because air, which is what's usually in our lungs, pure oxygen, oxygen, air is just clear. So you should only see white bones. But if you have fluid in the lungs, you're going to see white infiltrates. You're going to see white in the chest x-ray because of the fluid in your lungs. So you get a chest x-ray. All right? Now, one of the things too, we're going to do an ABG. I'll probably get a CBC because I got to know how many red blood cells I have carrying oxygen around. All right? I want an ABG to be checking for my oxygenation and CO2. Now up here, the first thing I want is a diuretic. And usually it's Lasix, but remember, people who've been on Lasix a long time, Lasix is ototoxic and nephrotoxic. And how you remember that, and I'll be going over this on the farm disc, when you were in utero, as a little zygote in your mom's uterus, your ear and your kidney were formed at the same time from the same germ layer as you were developing. So if a drug is ototoxic, it's nephrotoxic. If a drug is nephrotoxic, it's ototoxic. So that Lasix will really hurt your nephrons if you IV push it too fast. It's nephrotoxic, and it can make your patient transiently deaf. So meaning they'll get their hearing back, but you don't need, they already got enough problems. Why are you going to IV push your Lasix real fast? Do it slowly over 2 minutes, usually diluted in a 10 ml syringe, push it slowly, and then you're protecting the nephrons and you're protecting the ears so that they don't become transiently deaf. So for left-sided heart failure, we're going to give, and remember, being on Lasix is an intrarenal condition. It's already now a problem for the kidneys. So when we get to the renal discs, you'll see we'll go over Lasix again and how it can be harmful to the kidneys. So we'll be doing diuretics. We will do positive inotrope medications. This could be digoxin, calcium channel blockers, CCB, or beta blockers, BB, depending on what the doc wants to order, okay? So this is going to slow down the heart. Anytime that the heart slows down and lets the ventricles get better filling, we'll get a better cardiac output. We're going to do we did diuretics, we did inotropes. The next thing we could do is sometimes you'll see them order morphine for dilation, nitrates, or Natracor. And remember, Natracor is a man-made BNP, so if they're on a Natracor drip to cause vasodilation, you're not going to do a daily BNP. It doesn't make sense. Another lab value we would order is either a complete metabolic panel, CMP, or a basic metabolic panel. I like a complete, and I'm going to add a MAG level. For some reason, MAG levels are not done in our CBC or in our CMP and BMP. Should be, but you have to order it separately. And I have worked in a lot of different states, in different places, and you always have to order your MAG level extra. Because now how I like to look at this is I'm like, okay, my BMP should be under 100. If it's higher, I'm in CHF. I'll have a high CVP level. My chest x-ray will have some whiteouts. And why do I want to be looking at my electrolytes? Because I got to look at my potassium level because I'm giving Lasix. So I got to be watching that, right? Plus in this, I want to look at my BUN and creatinine because When it comes to my CBC, I need to be looking at my BUN and creatinine because I'm giving Lasix. That's kind of rough on the kidneys. We want to be looking at that. I'm going to be looking at my ABG because I want to see if I have PaO2 over 60, because if it's under 60, I'm in respiratory failure. And I want to see that my CO2 levels are normal, that I'm not retaining CO2, and we're going to go over what CO2 does. CO2 is a potent vasodilator, and we will go over what that does to our blood vessels when we're talking about ABGs. Now here, what does this mean to me in nursing interventions? Well, here, if I get an S3 and crackles in my patient, I better be assessing heart and lung sounds, because I know I'm looking for less crackles and my S3 to go away once I've been giving them their medications. I would be assessing their O2 sat. I would be checking my labs over here. I would be administering my medications. I would also be making sure I have an accurate I&O, because I have a decreaser in output when I'm retaining fluid, and when I give Lasix, I'm going to start really getting that fluid flowing out of the body. So I need to have a good I&O. These are the nursing priorities, okay, when it comes to this. Assessing lung and heart sounds, looking for an S3, crackles, shortness of breath, checking the O2 sat, checking my ABGs. And on the ABG disc, we go over oxyhemoglobin dissociation curve, what CO2 does to blood pressure, everything. And ABGs used to be panic-stricken for me to call a doc, and I was like, I would be dialing his number saying, please don't ask me a question, please don't ask me a question, because I did not understand ABGs. I did not understand alkalosis and acidosis and what that does to the ability of hemoglobin and oxygen to bind or diffuse to my tissues. We'll go over that on the ABG disc. You also want to be checking all your labs and looking at your BUN, creatinine, and your electrolytes, because we are giving all these lovely medications that will affect the electrolytes. I must be checking my vital signs often, because I'm going to give a diuretic. Now, that right there, we said, is one of the things that affects blood pressure. I'm going to be removing fluid. I am also dilating the lumen with nitrates or calcium channel blocker or beta blocker to make the workload on the left side of the heart easier. I'm dilating. So that's going to drop my map. If I give dig, calcium, or beta, that's slowing down my heart rate too. So here I have all three things that give me blood pressure. I'm dilating, slowing down heart, and removing fluid. So you better really be watching your blood pressure in your map and your urine output to make sure that you're perfusing well. Okay? All right, that pretty much concludes this first section of Cardiac 1. In Cardiac 2, I'll be going over all the medications. We'll be going into further function of the heart. Thank you very much.